So in certain clinical scenarios, you need to be careful with interpreting the TSH test. So the first one is any severe acute illness or non-thyroidal illness, an illness not due to the thyroid, which is the sick euthyroid syndrome. We're going to talk about that next. And then sometimes TSH can be high or elevated, but there is no clinical or subclinical hypothyroidism. For example, if the patient is having TSH secretory pituitary tumor, an MRI might be helpful in these situations. In thyroid hormone resistance. And then sometimes it could be just like an AC artifact. So a lot of times it's recommended that you repeat the test before you start treatment. And if the TSH level is really, really low, like especially if it's less than 0.01, basically undetectable, then it's almost always indicate thyrotoxic causes. But sometimes if the level is low, but it's not that low, then you need to think about some situations which can lead to low TSH level, like sometimes in pregnancy, especially during the first trimester, and this is because of the effect of the HCG, which can stimulate the thyroid stimulating hormone receptor and increase the level of T3 and T4 and decrease the level of TSH. Another situation is after treatment of hyperthyroidism, the patient might still have some low TSH levels. Don't assume that the patient is not complying with the medications. You just check the TSH after a few weeks or months, and not immediately. And then some medications, we talked about some drugs that can affect the level of TSH, including high doses of steroid or dopamine. And then it could be just acid problem, especially if the patient is taking biotin supplements, which are common in multivitamins. So these can sometimes interfere with the assays used because of the way that the antibodies that they use to detect the TSH, they can be affected or biotinylated, and this can affect the measurement level. Also, if you're suspected or a patient is known to have a pituitary disease, you need to be careful in these situations. This is secondary hypothyroidism, and in these situations the TSH can be really very variable. It can be low, it can be normal high, or a little bit high, which would be inappropriate for a low TSH level, right? If the TSH is low, the T4 is low, then I expect the TSH to be in the higher side. If it's normal, this is inappropriately normal. So in these situations, pituitary disease, that again, TSH can be misleading. So you really shouldn't use TSH in these situations as an isolated lab test to check the thyroid function and to monitor the progression of the disease. Okay, now we're going to talk about the sick euthyroid syndrome, or SES, or the non-thyroidal illness syndrome, or some people call it the low T3 syndrome. Sometimes low T4, but low T3 actually is more appropriate. So basically this is due to any acute severe illness can actually cause the syndrome, and even in structurally and functionally normal thyroid disease before the acute illness. So in these situations, the measurement of thyroid function test will be misleading. Again, any acute severe illness, especially critically ill patient, these are the patients who can have the sick euthyroid syndrome. So it could be due to the release of inflammatory markers. We talked about that earlier, but mostly could interleukins or cytokines are the major ones responsible for the pathophysiology of SES. As you can imagine, patients in the ICU who are critically ill are the most likely to develop the SES. 70% in one study had abnormal thyroid function without an underlying thyroid disease. Now, which is kind of interesting is the finding that there are actually some structure as well as the functional changes that can happen in the thyroid itself. Sometimes the thyroid might increase in size, or there might be like decrease in the size of fibrosis because of the inflammation inside the thyroid tissue itself as a result of this acute illness, not because of the underlying thyroid disease. Now, the usual pattern, and I think that's really important to note. So usually what happens with the thyroid function test in acute illness, it's partly due associated with the severity of the illness. So the first change usually that happens is a decrease in the total and the free T3 and the increase in the reverse T3. This could be due to these early changes could be due to inhibition of the deiodinase 1 and stimulation of the deiodinase 3. And in the first video we talked about the deiodinase 3 being responsible for conversion of T3 to reverse T4 to reverse T3, and that's why partly why the reverse T3 is elevated in this illness. But usually the free T3 is the first an early change that happens. That's why some people call it the low T3 syndrome. It's probably the most persistent change associated with the disease. And then when it comes to TSH, it's usually inappropriately normal because when the T3 and T4 are low, the TSH is supposed to go up, but usually it's inappropriately low. And later in the course of the disease, especially if it's a severe illness, it actually could be low. But usually it's not very low. So if it's undetectable, it could most likely indicate a true thyroid or primary thyroid disease. And then for T4, it's usually normal at the beginning, especially with mild disease, but later in the disease, it can go down, partly because of decrease of the binding of the T4 to its serum binding proteins. The free T4 can be low, normal, or high, but most of the time, again, the T4 is usually low when during the acute illness. So that's kind of the usual pattern, and I will show a nice diagram next. So if you look at this, you might think that the patient is having central hypothyroidism because the TSH could be normal or low, and the T3 and T4 could be low. So it could be confusing sometimes, so keep that in mind when you're interpreting this thyroid function test in these patients. Theoretically or pathophysiologically, people think that it's because of the acute illness, the body is trying to kind of cool down the inflammatory process and make it a little bit less damaging. Maybe that's what is happening. Usually recovery happens from top to bottom. So TSH start to recover first, followed by the T4 and lastly T3. And this diagram actually shows all this. So in the mild to moderate acute illness, usually the T3 is the first to change and to be depressed and go down, and the reverse T3 gets elevated to get high, and then sometimes the T4 might be elevated, but not always. But with severe illness, this is when you know that the TSH, the T4, and the T3, all of them are below the normal range, and this is where it really mimics secondary hypothyroidism. And then after this severe illness, if the patient recovers, then recovery happens with the TSH first, gets to normal first, and then the T4 followed lastly by the T3. I think that's really important pattern that you keep in mind when you're interpreting the thyroid function test if you have a patient who was recently admitted for acute illness in the hospital or ICU. Now, to make it even more interesting, this syndrome, there's certain disorders or diseases that might exhibit a little bit different pattern of the thyroid function. Again, this is not 100%. It's not conclusive, but you might observe some of these changes. So, for example, in some patient with acute liver disease, there might be initial rise in the total T3 and T4, but not the free T3 and T4. It could be due to release of the thyroxine binding globulin, which is synthesized by the liver, and that can get released because of the liver disease. And this rise in the TBG could be the cause of the increase of the T3 and T4. But down the road, as the disease progresses, then these levels will go down. Some patient with acute psychiatric illness, they might have a transient increase in the total and free T4 levels, usually with a normal T3 in about up to 30% of patients. TSH values in this patient may be transiently low, normal, or high. Patient with HIV in the early stages, they might have T3 and T4 levels up instead of normal or low. and T3 levels might fall with progression of the HIV, but TSH usually remains normal. In some patients with renal disease, it could be accompanied by a low T3 concentrations, but usually with a normal rather than increased reverse T3 levels, which happens most of the time, as we saw previously. This could be due to the presence of a factor that might increase the uptake of the reverse T3 into the liver, and that can be associated with a normal rather than high reverse T3 level. So again, these patterns are not 100% inclusive, and they don't happen all the time, but it's just an observation that some expert noted in these patients, which kind of make the picture even more confusing sometimes, and just kind of emphasizing the fact that the sick euthyroid syndrome, it doesn't have like just one particular pattern. It could be really different patterns. You really have to keep that in mind in these patients. So having said that, as you can imagine, really the diagnosis of SES can be challenging sometimes. Sometimes you don't know the past medical history of the patient, especially if they're acutely sick. You don't know if they have any previous history of thyroid or not. That might not be revealing at the beginning of the course or the illness. And the patient might have some other metabolic problems and other organs when they're severely sick. So some clinical and lab features to keep in mind and try to obtain in this patient. Try to see if you can obtain any prior labs for the patient regarding thyroid function test that has been done before. And then also look into the time course of the acute illness and the severity of the illness, because that also can affect the levels, as we saw in the diagram. Looking closely into the medications, prescription medications, over-the-counter medications, or even herbal medications, because we know these medications a lot of medications can actually affect the thyroid function, and they can be contributing to the acute illness as well. And then sometimes measuring the reverse T3 might be helpful, since it's the one that's kind of most likely or persistently being elevated compared to the other thyroid function hormones, or thyroid function tests, or thyroid hormones that we usually measure. So the diagnosis is usually presumptive to the most part, right? So basically you test or repeat if you're not really suspecting thyroid disease at the beginning of the illness, and you don't think that the acute illness is due to primarily thyroid problem, then you need to treat the patient and then follow the patient down the road, and maybe repeat the thyroid function test in a few weeks or a couple of months. And then depending on the pattern, then you can decide whether the patient before had sick euthyroid syndrome or not. So this is kind of a presumptive diagnosis, depending it's case by case, depending on the clinical scenario. And as you can imagine also, because it's unlikely that we're going to have like a big randomized control trial for this, because it's very variable, then the treatment is also variable, and we really don't know if replacing thyroid hormones when they have low thyroid hormones would be helpful. We really don't know that. Most of the experts, they actually just recommending monitoring of the thyroid function and just monitoring the patient. Don't give them thyroid hormones if their thyroid hormones are low at the beginning, and just repeat the thyroid function test in a few weeks and see what happens, and see what are the numbers after that. That's probably a better initial step. Just to summarize what we talked about, so with rare exceptions, the normal TSH level almost excludes a primary abnormality of the thyroid function test outside of acute illness, and single measurement of TSH is adequate for assessing its circulating level despite its pulsatile nature. And do not order thyroid function test unless you're really suspecting a primary thyroid problem as the cause of the acute illness, because the levels can change in these situations. And inacute illness can be associated with abnormal levels of TSH, T3, and T4. And then any severe or critical illness, they actually can mimic secondary hypothyroidism with low T3, low T4, and low or inappropriately normal TSH. So be careful in interpreting the thyroid function in these situations. And if you're suspecting sick euthyroid syndrome, do not treat the thyroid hormone. Treat the patient, follow them up, and just repeat the test in few weeks or a couple of months, and then depending on the numbers, then you can treat the patient if they're still having persistently abnormal thyroid function or if they're symptomatic. But most of the time, if it's SES, then the thyroid function is expected to recover. So thank you very much, and hopefully all of you get a healthy and happy thyroid. Bye-bye.